Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, Healthcare CIO coach and creator of This Week in Health IT, a set of podcast videos and collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. Now we're exiting the series, and Sirius has stepped up to be a weekly sponsor through the end of the year. And we want to give a special thanks to Sirius for supporting the show's efforts during the crisis and beyond. Don't forget, we've gone to 3 shows a week now. Tuesday, we cover the news. Wednesday and Friday, we do shows with industry influencers like today. I want to thank everyone for your support of the show. We've eclipsed 100,000 downloads for the first 6 months of this year, which, as you recall, is what we had for the entire 2019 year. You continue to make this the fastest growing podcast in the health IT space. Thanks for sharing it with your peers. To make it easier for you to share it with your peers, we're launching a thing called Clip Notes, which is essentially a summary of each podcast that comes into your inbox. Think of it this way. What we're going to do is we're going to send you a single email for every episode that we do. It's going to have a 1-paragraph summary of what we cover. It's going to have bullet points with key topics and timestamps so you can determine where to go within the podcast to listen to what you want to listen to. And we are also going to have a couple of clips, 1 to 4 clips from the show, the shorter segments, 3 to 5 minute clips of the show that might cover a specific topic. You're going to have that within 24 hours of the show being released. And, the thing that excites me the most about it is I had conversations with CIOs during the pandemic, during the peak of the pandemic, and they were talking about how they didn't have enough time to consume all the content, and they wanted a way to skim the content. And that's why we came up with Clip Notes. What our hope is that you're going to be able to get this in your inbox, review it, and then forward it on to key members of your staff or key people you work with so that they can have the benefit of some of the conversations that we're doing right here. There's 2 ways to sign up. You can go to the website, go to resources, click on Clip Notes, and click on the subscribe now. You can put in your information and you will be signed up. The other way, we're trying to make this as easy as possible. Send an email to clipnotes@thisweekinhealthit.com. You're going to receive a link that comes right back to you in your email. You click on that link and you can sign up that way. So we're trying to make this easy and hope to get as many of you signed up for that as possible so that we can continue to share the content from the show. As always, special thanks to our channel sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, and ProTalent Advisors, whose investment in the show has given us the ability to hire additional staff and to provide these great services. So I did this show a little while ago. I recorded this probably about almost 8 weeks ago now, and didn't get a chance to air it. We had so many shows recorded and so much in the pipeline that I didn't get a chance to release it. But I wanted to get it out there for you and for the community. I had a discussion with partners of the show around what is going to be next within the hospital. What is the patient room next going to look like? And we had a good conversation, recorded it here for you. Hope you enjoy.
The patient room next is what we're calling this conversation. Our panel for today is Fred Holston, Ed Ricks, and Eli Tarlow from Sirius Healthcare. Gentlemen, welcome to the show.
Thank you, Bill.
Thank you.
All right. So, I've been reading a lot, and I'm sure you guys have been reading a lot on the impact of COVID-19 on healthcare, but some of it has really accelerated the move to digital at an amazing speed. Jackwitz, who's the CEO of USC, shared that they did 300 total telehealth visits in 2018 and 5,000 over the last 2.5 weeks. But before we jump into this, why don't each of you give maybe 30 seconds on your healthcare background? That way we'll sort of set up the conversation. Eli, we'll just start with you.
Thank you, Bill, and thanks for having us on this podcast. So I've been with Sirius for about 2 months now. Before I joined, I was most recently a CIO at Brookdale Hospital in Brooklyn, New York for a couple of years. Before that, I was CIO for a couple other hospitals, notably Bellevue Hospital and Metropolitan Hospital in the city. And I held other healthcare IT leadership roles in both public and non-public healthcare since 2001.
Fantastic. So you'll represent the CIO perspective on this show, which is great. Ed, do you want to introduce yourself?
Yeah, thanks, Bill. Appreciate it. Prior to joining Sirius, I've been with Sirius for, just about 2 years now. But before that, about 20 years, primarily as a health system CIO around the Midwest and the Northeast and Southeast. But the last 9 years in a town called Beaufort, South Carolina, where I spent probably the last 3.5 years as the COO there, and sort of still had IT, but led operations of all the ancillary departments and service departments and our population health initiatives.
Great. So we're going to have you take the COO perspective. And Fred, give us a little bit of your background.
Sure. Fred Holston, Director of Healthcare here at Sirius. Been with Sirius for just a hair over five years. Excuse me. Came from Intermountain Healthcare as their Chief Technology Officer. I also left as the Creator and Executive Director of the Innovation Lab, which we call the Transformation Lab there at Intermountain.
Fantastic. So there's your CTO's perspective. So CIO, COO, CTO, and what we're going to talk about is the changing landscape of the patient room and really the hospital just in general. You know, the number of digital initiatives, as we touched on earlier, and the pace at which we just accomplished it is pretty staggering. Jonathan Manis, the CIO for Christus, wrote in Modern Healthcare just today that you know, the cat is really out of the bag, and we are likely never going back to that digital. We've experienced digital, and our consumers have experienced digital, and it will change things for good, is what he believes. And, you know, I guess my first question is, why is that a good thing? And, you know, let's start with the COO's perspective. Why is that a good thing that digital is going to take hold for the business of healthcare or for the operations of healthcare, you know, moving forward?
Yeah, I think if you remove the clinical benefit, which it's going to be huge in that, probably above anything else, we're going to create some of the efficiencies that other industries have been working with for 15 years. You know, the way they've used digital and sort of input it into their business, from buildings to operations to people, in the way they actually manage what's going on. So to me, that's going to be one of the biggest gains, certainly, because there's so much technology available that we've underutilized from an operational perspective for years that will be integrated into our day-to-day lives, probably.
Yeah, it is. It will be interesting to see, and we'll go into more detail of where that sort of integrates and what that looks like in the hospital. You know, Eli, from a CIO perspective, digital's taking hold. Why is that a good thing?
Well, first of all, why digital hasn't taken hold historically in healthcare, and you know, we can spend hours talking about why the healthcare industry lags behind others in as it relates to technology. You know, for one reason, healthcare, we have to be more risk adverse or risk balanced. It is human life. It's science as well as art. But with every crisis, there comes opportunity, and with most recently with the coronavirus, a lot of the things that we're seeing in the last 2 weeks are things that we haven't been able to progress on, whether it was for funding reasons, legal reasons, et cetera, that have now really propelled and has gone far in the last couple of weeks. I'm personally excited about a lot of the things we'll be able to accomplish, and I really excited about the fact that that'll be sticking, as you pointed out.
Yeah, it will be interesting. You know, Fred, from your perspective, you know, we've talked about, you know, patient room now, next, and future, and the technology foundation for that. You know, why is it a good thing that the digital technologies will be coming in? You know, were there challenges with the existing technology? Were there things we were unable to do that now we're going to be able to do?
Well, I think so. Part of it was that we wanted digital technology or technologies, I won't necessarily say they were all digital, to influence healthcare, whether that's decision support, protocol support, whether that's the EHR, regardless of what it is. But we kept layering those on without figuring out the workflows. And the workflows now have gotten, we used to call it, we needed a tool belt for a nurse because there were so many things they needed to carry around or do, too many computers to type on. So there's two pieces of the digital side. One is that we're going to hopefully create better workflows and that the computer does more but actually gets out of the way. But the other is that in many of our healthcare patient rooms, we can't do the surveillance or monitoring of patients like we really would like to. If you hook them up to a heart monitor, that's one thing. Ventilator, that's one thing. A pump, that's one thing. But when they're just in the patient room, who's watching them? The nurse can't be there all the time. The family may or may not be there all the time. The digital influence on what we're going to be able to watch going forward and what we're going to be able to learn about people and how we change their care minute to minute, and then as they go home with what we're going to be able to watch, I think will be a huge impact in the future.
Yeah, I agree. So the COVID-19 pandemic that we're currently dealing with, we've seen organizations revamp those workflows on the fly, right? And so we've put some things in place, and we revamped some of the workflows, and obviously some of that stuff will have to be thought about when we're not in a moment of crisis. So let's fast forward a little bit, because we could talk about now, but right now people are still sort of battling through crisis mode, and it's amazing that we stood these things up. They're filling gaps. But if we were to step back and start to think about setting this up in a way that is purpose built, planned, thought through, in order to get the best outcomes for the health system. Ed, we'll start with you. What kind of outcomes are we looking for? What kind of workflows and what kind of outcomes would we be looking for from the really transitioning from brick and mortar to more technology enabled workflows and processes?
Yeah, I think the word that always comes to mind for me, Bill, is flexibility, right? So Eli mentioned sort of necessity is the mother of invention, and so people are accelerating what they're doing today, which is incredible. When I'm talking to friends in the industry, what they've done in the last 2 or 3 weeks, it probably is more than they've done from a change perspective in the last 2 or 3 years, really, when you think about their clinical workflow and everything through the organization. So building flexibility, thinking more virtually beyond the bricks and mortar, because we're sort of stuck with the bricks and mortar that we have, from a room perspective, and I know we'll get into some other concepts in a little bit, but today we have what we have, right? So you're seeing the pop-up tents, you're seeing people converting recovery rooms to temporary ICUs and things like that really quickly, and the plans were probably always in place for that, but now it's going into action, and you learn from that, which is the other good thing really from this, is everything that people are going to learn, what they can improve on. So, most organizations over the last 15 years or so have adopted some sort of maybe lean technology for performance improvement. And this is really accelerating that even. And so it is like, make a change. Is it better? Good. If it's not better, make a different change and keep going on. And that is the stuff that sort of really excites me and energizes me on what people are doing.
Yeah, absolutely. Eli and Fred, I'd like to really hear both of you sort of weigh in on, what does it look like? So we want to build agility in, and we've seen some of this play out, right? So the health IT really has been kind of the best supporting actor in this whole thing of ramping things up with a certain amount of agility. So we had some systems in place to make the transition for rooms and those kind of things. Is that going to be the design criteria moving forward? Agility, being able to respond in a crisis and being able to build new workflows and those kind of things. And Eli, I guess we'll start with you. How are we thinking about the technology at this point?
Sure. Thanks, Bill. So I would answer that in 2 ways. The first is that, as Ed mentioned, it's about having flexibility or making so that they're modular, because we don't know what the next crisis will be, and we need that kind of flexibility or the ability to just change purpose. But the second thing I want to really focus in on is that what coronavirus and repurposing of space has really amplified, something that we've known for a while, is that hospitals are really, really becoming more care centers for the highest level of acuity. Previously, over decades, people went to hospitals for many things that are now being taken care of in ambulatory care settings. It's moving to home health. It's moving to telehealth. It's moving outside, long-term care, post-acute, et cetera. And the hospitals, the brick and mortar buildings, are becoming more and more where patients have no other place to go. Now with this latest epidemic, that's exactly what we're seeing. People are making choices. They're saying, okay, I'm going to go to the hospital if, God forbid, not if I have a virus. I'll go to my primary care physician. I'll go to a pop-up, I hate to use that term, but a clinic, a CVS, just if I think I have the symptoms, and I'll only go to the brick and mortar hospital if it's life-saving. And I think that's really A, what the hospitals are going to become, and B, in how we design it from a technology standpoint. That has to really become our true north if it isn't there already. We have to start to think about the patient rooms, not just how can I turn a med-surg bed into an EICU, but how can I continue to turn the hospital into the higher level of care place. So I think, we have to look at those rooms, the wards, the units, the services, and how do we kind of align the technology strategies for that, and keeping it somewhat flexible because we won't get there overnight. But B is that's really what those buildings are going to become. So how do we make sure that whatever our investments are, that they make sense in a decade from now?
And Fred, I'm just going to ask you to build on that. But Eli, I'm not sure we can say that anymore. We can't build it overnight because we just did. We built a ton of stuff overnight. It's unbelievable. Fred, do you want to build on what Eli's talking about?
Yeah, I mean, I think we were headed there anyway. I think as the shift to community care, more outpatient care, as Eli was talking about, shifts, and really that hospital becomes this, it ebb and flows between, well, if I've got room, I'll keep people for observation. If I don't have room, people for observation may go home and be centered up, as they go home. And so that room was always needing to change for the future so that we could ebb and flow it. What's really needing, though, to change in situations like this is how do you help? Because clinical equipment is one issue, staffing is another. Well, there've always been staff on the floor for those rooms, but they're not always necessarily fully trained on the protocols for certain critical or ICU situations. So how can you now have the room rise to help them with those protocols, those step-by-steps, the distance specialists, those kinds of things. And so it's always been on that path, but I think now we have a reason to expedite that path.
One of the things that I'm struck as I hear you guys talking is just how integrated the technology tool set's going to be, and the physical design and plan, and how we sort of plan these things. And you guys have probably been through building projects. I've been through building projects. It's amazing to me how much of an afterthought IT was in those building projects way back in the day. I mean, it was essentially, we set aside this much money, just make sure that the room can do what it needs to do, was sort of the conversation. But it sounds like what you're saying is we're going to have to think about the workflows. It's almost like we're completely changing how we think about how we provide care, what's the proper setting, getting them to the right setting, providing higher level of acuity care in certain instances, maybe a certain higher level of acuity care out of the home with remote monitoring and those kind of things. Are we going to be rethinking the whole paradigm of what goes on in the hospital and in the workflows across the board? Is that what I hear you guys saying?
If I can jump in, Bill, Fred will smile. Fred and I spent a big part of last week, actually. We were asked by a hospital in the tri-state area in Connecticut, actually, and they're building new brick and mortar property. And they asked us, actually, before they stick a shovel in the ground, to help them design their technology stack for that building. And a lot of what we're talking about today, so they haven't even begun, construction on it. And they're really asking us to help them think about these things. So that's a forward-thinking organization. I wish all were the same, but we're starting to see that more and more, where our clients or hospitals are starting to say, hold on a second, how do we, we have an opportunity, whether it's a new building, it's repurposing something, different types of opportunities come to us, and they're stopping to say, hold on a second, before we do anything, how do we prepare this to be something that makes sense for a long time?
So, Ed, what kind of business questions are we asking? Are we rethinking some of our normal business practices?
You have to, and I think it does start with the technology, though, and it's sort of that thought leadership to be in advance of the building. So Fred nailed it. In the future, I think that acute care hospitals will be for extremely acute patients, and that's it. That's all we're going to do are procedural things. Everyone else is going to be treated some other step-down way or at home or whatever it could be, and the technology brings the clinical process together to that. So I think the business questions are, can we make any place flexible enough to be a very high level of acuity? May not always use it that way, right? But you got to plan ahead. And I think if you're not planning ahead, then you're sort of short-shifting yourself later. So to me, it's looking at that. It is, how do we use technology not to be in the way, but to be invisible to the clinicians? As also a CIO for 20 years, I know I was a very big part of the problem of sort of screwing up the clinician's life and workflow, all for the right reasons, and we can say whatever drove us, if it was to be meaningful use, if it was to be, compliant with some regulation, whatever it was, we were still glorifying EHRs as billing systems and letting the clinicians pay the price for that. And I think that the effort now is let's look ahead. How can we get the most advantage out of those clinicians, who are fewer and fewer, by the way, and I think the workforce in the future is going to be an issue, and we may talk about that later. How can we get the most out of their skill set without invading or, being in the way, being a barrier to what they do, and, making that technology more invisible from thinking of it in advance, not as an add-on, which is what we've historically done.
All right, so we've talked about the why. We've even talked about somewhat the what that we're going to do. We're going to remap these. We're going to remap our care settings. We're going to raise acuity and do those things. Let's start to talk about the how. And Fred, I think we're going to start with you on the how, which is, how do we do this? What does it look like? Is it the same way we put in a foundation for the physical building? We're going to put in a technology foundation to support this, and a business process foundation, and a staffing foundation. I mean, what does it look like to do this?
Yeah, so we're viewing it as, in the foundation side of your comment, what are all the sensors we could be putting in the room to make the room work for us and collect data? I mean, part of this is knowing what's going on, collecting the data, everything from touch, and we're looking at touchless. How do you do touchless vitals? How do you do touchless proof of life? How do you do touchless movement? How do you model the data that you're getting to say an action's happening? If you look at one of our goals when we look at Patient Room Next, we really want the actions of what nurses and doctors are doing to create documentation, to get out of pecking on the computer. Do what you do it well, and while you're doing it, we'll create the documentation. Oh, and by the way, when you're not there physically around the patient, we'll look at what's going on and be able to alert you ahead of something going wrong, ahead of a code blue, or ahead of a fall, or ahead of whatever it happens to be. Those all start with putting the right types of sensors. There's thousands of sensors out there. You can imagine, call them IoT, call them whatever you want, but there is a subset of those that are really good at what they do. And we can put those in, make them part of the infrastructure, take the data from that, build models, and as we get smarter over time, we'll build more models, we'll load those models, and we'll get smarter over time, we'll load those models and continue this evolution. And then for staff, hopefully we will be changing their workflows in such a way that they become more efficient. They're doing the things that, number one, they like to do. Most nurses get into it because they like to take care of people. It's not just a job, they like to take care of people. My brother's a physician. He got into it because he likes to take care of and help people. Let him get back to doing that and doing it well. But the other piece I think that'll change is the satisfaction of our patients, whether that's family members that we're trying to deal with or satisfaction. And I won't say mental health necessarily, but the mental attitude of people in the hospital. Are they satisfied? Are they distracted? And do they feel like they're being taken care of? Can we provide digital companions that allow them to feel like they're being taken care of? And then when they transition out of the traditional brick and mortar back home, can those companions go and continue that care as we move them from one care environment to another? So there are a lot of things that'll come along, and it starts with kind of this fundamental foundation of let's get the right sensors in there and start this process of getting data and modeling that.
Wow, that is interesting to me in that, first of all, you mentioned a lot of technologies that are already out there. I think we're talking about the next iteration of this, and some people might think, oh, that's way off what you're talking about. But we've already had Nuance and others on the show talking about ambient clinical listening. IoT, we've seen things from a lot of different vendors. Some of them are really sophisticated, the amount of data and the things that they can actually monitor that are going on in the room. As you said, that the technical jargon for it would be IoT, but there are thousands of IoT devices. So is this another one of those cases where there's a ton of technologies and we really have to figure out a way to, again, we don't want the technology to lead the business problem. right? This is how we get in, this is how we get in trouble, how we've gotten in trouble over the years. We really want to step back and understand the business and then start to put those things in. Are we seeing business models start to move in this direction? I mean, Intermountain was one as the EICU, or actually they have the digital hospital, right? It's Mercy in St. Louis that has the EICU and others. Do we think that that's going to be, one of the more prevalent business models that we're going to see people are going to rethink the hospital and start to provide those digital services for their community?
I can add. No, go ahead, Fred.
No, I just think that there's no doubt. There's zero doubt in my mind they're going to be rethinking that. One of the things that occurred in all the healthcare legislation for the past number of years, patients feel empowered and patients want to work a certain way with their health system. And that is now driving I'm a patient. How do I want care? And it's driving that. And it's not just a cool digital app that's out on your phone. It's the entire process. So I think this entire rethinking of what do we provide. But the good news about that is it isn't just, we have to do this because that's what customer service of our patients and satisfaction they want. It really can be a game changer of how we can lower our costs, improve patient outcomes, and actually make our physicians and nurses more happy in what they do. And at the end of the day, collect more data that will help us in the long-term research of, how we solve bigger medical and healthcare problems.
Yeah, and that's one of the things. I'm going to come back to the how in a minute, but that's one of the things I wanted to touch on with you guys. And I'm sorry, I'm throwing you curveballs. I'm just throwing a question out there to all three of you and letting you jump on each other. So I apologize. But I'd almost rather have that. Whoever can jump in, feel free to jump in. But I want to talk about the customer experience. Because, we've seen these, we've had people come in and say, why aren't you more like these customer service organizations who have, thought through this and put in digital tools and all that other stuff. And to be honest, we responded with things like, a patient portal. And we responded with things and people were just like, yeah, that's really what we were doing in, 2000, but this is 2020. So, how do we get to the tools that really think through how we want to receive care, really from the patient perspective, right? I need a ride to somewhere. I need someone to bring me my drugs. I need someone to monitor me for falls, not only in the hospital room, but in my home. I need somebody to, check my temp. I mean, literally, we could set up pretty interesting things out of the home if that's what people require of us as a health system. So talk about the patient experience. What do you think is going to change as a result of the COVID-19 situation we're going through right now, that patients are going to go, hey, you know what? This is my new expectation from healthcare. And again, I'll throw it out to all three of you. Whoever wants to go, just raise your hand.
So all
right, next time I'm going to raise my hands quicker.
So
it gets the call.
So a lot of what you just talked about, Bill, was traditional, IT organizations or manufacturers of EHRs, et cetera. The way they attacked the patient experience was by building on their existing tool set. So you mentioned the patient portal, right? So a manufacturer, an EHR company that has a EHR can now open it up and say, okay, I want to, cut out this section of data, make it patient facing, and now voila, you have patient experience, right? What we're seeing more and more now are things that are coming totally from left field. So things that are being manufactured or created by companies that have not been in the healthcare arena. And this is nothing new. This has been going on for a while now. And they're modeling it after other industries. It could be anything from loyalty programs. It doesn't have to even be, patient experience doesn't necessarily have to be, a way to see their vitals. It could be like, modeling after the gaming industry and loyalty. It could be modeling, you mentioned now they're sending cars, taking Uber or whatever to send cars to lower patient cancellations and improve access. So I think the genesis of patient experience was, okay, what can we do with the tools we have? And it's completely turned around. We're saying what's available out there and how can we benefit from that? Fred and I, and Ed, actually the three of us, we heard about a manufacturer that's using Alexa, which ties into COVID-19, which is moving towards using an Alexa to detect abnormalities in breathing patterns. One of the early symptoms of COVID-19 was shallow breathing. Imagine an elderly in a house who is having difficulty breathing, and ambient listening can now detect that against algorithms and other signatures of that person and set off alerts. That's not building on an EHR. So I think and that's obviously patient experience. So I think what we're seeing now is that ideas are coming from everywhere, and it is a little bit of a tsunami. Hospitals are going to be challenged with saying, okay, what makes sense? What can we adopt? What do we have to push off? What do we got to wait to see others, how they do with it? That's going to be the challenge, I think. It's going to be we're going from so little to so much.
Yeah.
I think another one of the problems that we're seeing as part of this is the evolution of how it's happening. I walked into one of our customers not too long ago, and when I walked in the lobby, there were 4 banners. And one banner said, hey, if you want to figure out where you're going inside of our hospital, download our wayfinding app, and there's one app. And then it said, hey, if you want to see your patient, whatever, download our portal app. Oh, and if you want to be part of this education thing, download this thing. And there was one other one. But the point being, our evolution is we're evolving by looking at, oh, we think people want this, and we're buying a solution, which is what we've done for the last 25, 30 plus years. We buy a solution that solves a very specific problem, and then we're looking at our patients, our doctors, and our nurses to try to figure out how to use all those too many applications. Where the shift is really going to occur, if you talk about the experience component of this, is we're going to have to create this one organization experience. We call it digital front door. It's overused. But this idea that you can create a relationship with somebody long before they become your patient. You can use them for goodness, and trying to keep them healthy and all those other things. But then when the day comes that they need something, whether that's minor or major, they have a relationship. That relationship leads them where they need to go. It helps along that way. And then ultimately it sends them back home, but keeps that ongoing relationship. And that's, I think, how we'll create an experience. So we lead them along that. It's kind of a one view of that world. And we feel like, even though we're multiple departments and specialties and people, and maybe even different organizations within the same organization, that it feels more like one. And I feel like I'm being taken care of from a clinical perspective. It becomes a branding issue. It becomes a satisfaction issue. It becomes a health issue, as well as that's really the way we need this to work going forward. And the room, as we talk about that, is one piece of that, right? We've got the pieces that occur before you ever get there, and then we've got what occurs in the room, but those are all part of the same ultimate conversation. How do we take care of people in that continuum of care when it's cheaper and most appropriate to take care of them, and before it gets to most expensive and it becomes more difficult?
Right. And oh, go ahead, Ed, please.
I was just going to say, I think that part of this whole thing is what's going to probably lead us there. It's kind of funny. So for the last 10 years, probably, we've been talking about the shift to consumerism and the fact that you are not going to remain financially viable if you can't figure out patient experience, and you're going to lose anything profitable in your system to the businesses that understand how to do that well, and there's a lot of them that are retail and really know how to connect to patients. And yet I still don't think we've done a great job, in healthcare in general. But you know what we do really good in healthcare? We respond to crisis. And I think that's the interesting thing right now. It's like, here's the real expectation that patients have. So yes, they are consumers now. Yes, they want all these things to improve the patient experience. And I know that we've got to get to that point, but they also want good care, and they want to make sure that they feel comfortable. They're going to, wherever they go, that they're going to get taken care of. They're going to save their lives. I mean, right now it's a real crisis, and you're seeing that response. And I think that's why you're seeing such a monumental shift so quickly. Like, let's throw up the pop-up tents. Let's bring in the mobile units. Let's find an unused dorm room, whatever, or, whatever it might be to get these temporary hospitals, because I think healthcare does that really well. We'll recover from this and then go on. And if you're already starting to put the building blocks in place for this shift to consumerism, and how do you fix that, not only patient experience, but Fred will mention, clinician experience, that's a big piece of this. I think that you'll be better suited for the future, regardless of the way reimbursement works, because that's a big piece of it, but really because that's what people have an expectation next for on everything.
Yeah, and actually, one of the things I think is really fascinating to me is we were sort of, as a industry, we were sort of plodding along, waiting for big tech or somebody to come in and completely upset us. I mean, literally, we were not responding as quickly in any one area, especially around the, a unified experience. And we were sort of waiting for it to happen to us. And it's really interesting because I think this has caused us to do just some of the things that we've really needed to do. And I keep coming back to telehealth just because it's the best example. Telehealth had a net promoter score of like 85 to 90%. There's almost nothing else that healthcare does that gets a 90% net promoter score. And we just implemented it across the board. Okay, that's great. That's one example. That's one piece of really being responsive to the consumer. But there's now a whole host of other things that we can do if we focus in and do these things. And what I think it's changed the trajectory. It used to be, hey, you know what? CVS is going to come along and eventually get in between us and our consumer, and away it goes. But the healthcare systems just jumped over CVS. CVS was going to be convenient because it was down the street. We're now going into the home, right? So that's fundamentally changing things. But I'm sorry, I digress. I'm going to go back to interviewing. Talk to me about the clinician experience. And Fred, you touched on this earlier. Why is it going to be fundamentally better? We've been saying it's going to be fundamentally better for a while, but it seems like we put technology in and it doesn't make their life better. Why is this fundamentally going to be better?
Well, let's put it this way. I certainly hope it's fundamentally better. The way we've done technology in the past is we've gone based on clinical workflows. We've not always looked at how nurses actually work in wherever environment they are, and how doctors actually want to work, and what do they need when at the most appropriate time. And as they're moving, not going in and saying, well, I got to review this chart. What can we tell them right here, right now, as they come in to see Bill, in order to have the best conversation or make the best recommendation on Bill right now? And I think that's where we have the opportunity to make it better. Look, there are lots of systems. There's EHRs, there's their labs. There are many other systems that they interact with that have information that they potentially have to put information in. But we have new and interesting opportunities to make it more like their workflow. And they just want to know, what do they need to know, when they need to know it, at the time they need to know it, so they can do their job the best and spend more time with the patient, less looking, again, which you see the nuance solution, right? What part of what that's for? Great documentation while spending more time directly with the patient. That's a great use of technology in order to create a better patient, doctor-physician relationship in that mode. But there are other things that we can bring along. So that will be one: machine vision, machine audio, content delivery, distraction, right, are all pieces of this grand, I think, future that we have.
Bill, I'll add to what Fred said. There's the component of patient experience where the provider has more time. A lot of that, like Fred mentioned, is ability to use technology to have more time when they're in the room. Telehealth and other forms of technology means that patients don't necessarily have to interact with the provider unless it's absolutely necessary, which gives the provider more time back in their day. But another thing that Fred alluded to earlier, which is from a clinician or provider satisfaction, are all the things that we're seeing technology such as sensors. I remember when the Ebola patient was at Bellevue Hospital. I know that everybody knows that story, and I was the CIO there at the time. One of the big challenges we had was entering the room. It was a long procedure to don and doff the PPE. It was an airborne pathogen, so there was inherent risk to the provider. And now one of the things that Fred is building on with the patient room next is the ability to care for the patient without even entering that perimeter, whether it's the sensors, all those types of touchless technology that's available. Physicians don't have to enter that area, the perimeter, where they can expose themselves to unnecessary risk. So, I can't think of a better clinician satisfier than their own health.
Yeah, absolutely. Ed, should we give you the last word on this, or who would like the last word on this?
Well, we all would. Fred deserves it because this has been his vision for a long time, and it's a big part of why I joined this team, just because of the way I think we think. We're very pragmatic. We want to solve problems. We don't want to sell parts. We don't want to do that. We're looking to the future, trying to tie it all together. I do think, so my piece of this is, I would say, being pragmatic. We can solve a lot of clinical efficiencies, a lot of workflow efficiencies think about space differently, think about digital differently in the way you tie things together. I love this concept of the future because that means maybe a greenfield, you building things away from a design process on up, thinking about digital instead of the retrofit. But I'd love to hear Fred's final thoughts.
No, I think I agree. And I think the other thing I also want to just make sure that we get across is that while we are a technology company, while we are looking at technology, I'm certainly a technologist by history, we're really taking two approaches to this, and they're being done at the same time. One is, how do we curate the technology and find the right pieces that will give us the kind of data that we need in order to answer a lot of these questions in the future? But the second piece is we're asking our customers, what are the most important things we could be doing? If we could check this box and take that off your plate or make this easier or solve this particular type of problem, do we impact cost? Do we impact satisfaction? Do we impact outcome of care? What are those clinical things that we could be doing? And how do we then marry those two? How do we take the data we're getting from all the technology and the capability we put in and marry that to what the real needs out there and try to check those in some kind of order that, and by the way, I don't know what that order is. It's different by organization, so we'll have to figure that out. It's different by doctors versus nurses versus patients and even the administrative side of the organization. But we're asking the questions as to what can we really and should we be solving so that we do this in some kind of, again, pragmatic and useful way that people actually want to use, and then how do we sell it and install it in such a way that they can use just what they need because that's what they need now. They're not ready for all the other cool whiz bang stuff that might could be done. Let that come as it's appropriate for it to come. Or for the next pandemic kind of situation that says, I need that, and it will be more prepared maybe to move those things a little faster.
Well, guys, this is an exciting future, I think. And I think there is a positive that comes out of this, as we talked about earlier, just and the positive is a healthcare that is more designed around the clinician and more designed around the patient and the patient experience. And hopefully some of the regulatory things that have kept us from doing some of this stuff in the past will open up as well. And I think the thing I've heard from you guys, the exciting thing is the technology has progressed in such a way that we can do things today that we haven't even thought about before, which gives us the ability to create some of these new processes supported by technology that gives people the joy of practicing clinical work again and the efficiencies that we need to give them the time that they really want to spend with each one of the patients. Gentlemen, thank you very much. I appreciate your time.
Thank you, Bill.
Thanks, Bill.
That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, you can check out our website, thisweekhealth.com, or the YouTube channel. If you want to support the show, best way to do that, share it with a peer. However you do that, send them an email, send them a whatever, DM, whatever you do, that's what you should do. We'll be back again with more shows as this progresses. We'll try to drop one a day until we flatten the curve. Thanks for listening. That's all for now.